Are guidelines for low back pain management being followed? You may have recently heard on a national news broadcast or in national newspapers that a new study published in 2013 revealed that in the U.S., the management of back pain by medical physicians has not followed the direction of national guidelines, leading to the unnecessary use of special imaging, narcotics, and surgery. So what did the study look at, and are there any lessons to be learned for both the medical healthcare system and the chiropractic marketing system? Let's start with an overview. More than 10% of visits to primary care physicians are due to back or neck complaints. In fact, back pain is the fifth most common reason for all physician visits. Conservative estimates are that back pain accounts for approximately $86 billion in healthcare spending annually, with indirect costs due to lost productivity estimated at an additional $20 billion per year. The study we're about to review is entitled Worsening Trends in the Management and Treatment of Back Pain, published in JAMA Internal Medicine in 2013. So what do guidelines stress? Well, that depends on the guideline, but many stress conservative management that may include manipulation, use of nonsteroidal anti-inflammatory drugs or acetaminophen, physical therapy, early activity, and avoiding early imaging or other aggressive treatments. The current study we're about to discuss utilized only one of these guidelines, published in 2007 in the Annals of Internal Medicine, entitled Diagnosis and Treatment of Low Back Pain, a Joint Clinical Practice Guideline from the American College of Physicians and the American Pain Society. Their summary had 7 recommendations, which included: conduct a focused history and exam, do not routinely obtain imaging, evaluate persistent low back pain, radiculopathy, or stenosis with MRI only if surgery or epidurals are being considered. Provide patients with information on the natural history of back pain and self-care. And consider the use of medications such as acetaminophen or NSAIDs as first-line choices. But let's focus, though, on recommendation 7, which was not mentioned in the recent study. For patients who do not improve with self-care options, clinicians should consider the addition of non-pharmacological therapy with proven benefit. For acute low back pain, spinal manipulation. For chronic or subacute low back pain, intensive interdisciplinary rehabilitation, exercise therapy, acupuncture, massage therapy, spinal manipulation, yoga, cognitive behavioral therapy, or progressive relaxation. In this recent JAMA study, the authors refer to a recent meta-analysis where researchers found that narcotics have no proven efficacy in chronic back pain. 43% of patients have concurrent substance abuse disorders, and aberrant medication-taking disorders are as high as 24% of cases. For special imaging use, the researchers quote one study that indicated that early MRI for acute back pain was associated with an 8-fold increased risk of surgery. Another study found that regions with more MRIs perform more operations, with 22% of the variability in spine surgery rates explained by rates of spine MRI use, and this is twice the predictive power of patient characteristics. And regarding the use of surgery, a recent study indicated that patients in a work comp system had a 42.7% chance of having surgery if they saw a surgeon as their first provider, compared to only 1.5% who saw a chiropractor first. Now, this current study utilized 2 related surveys over a 10-year period, the National Ambulatory Medical Care Survey and the National Hospital Ambulatory Medical Care Survey. The data consists of outpatient visits to hospital-based ambulatory departments, including outpatient clinics and visits to emergency departments. There were 3 stages. In the first stage of sampling, 112 primary sampling units were selected from among those used in the National Health Interview Survey. In the second stage, physician practices or hospitals were selected from within these primary sampling units, and finally, in the last stage, physicians or clinics sampled a subset of visits in their practices during a predefined period. Exclusion criteria were visits with concomitant red flag diagnoses or symptoms, including fever, weight loss, neurologic symptoms, cancer, spine fracture, myelopathy, or post-laminectomy syndrome, and a coexistent diagnosis with similar treatment options such as knee pain. The researchers measured mainly 3 things: 1. Referrals for physical therapy or to other physicians other than the primary care. 2. Use of imaging, including both CT or MRI and plain films. And 3. Use of medications, including NSAIDs and acetaminophen, narcotics, muscle relaxants, and anti-neuropathic pain meds such as gabapentin. An interesting finding regarding the proportion of cases that were acute versus chronic was that the proportion with acute or new onset symptoms decreased from 63.7% to 58.6% in the 10-year period, whereas those with long-term symptoms increased from 29.7% to 37.1% during that same period. Now to the results of the current study. In the study period, there was a 106% increase in referrals to other physicians who were more often than not likely to order special imaging, which often resulted in surgery. They found that with patients who had chronic symptoms, referrals to other physicians increased more rapidly when compared with those with acute symptoms. Referrals to other physicians increased from 3% to 13.4% for chronic symptoms, and from 6.7% to 10.5% for those with acute symptoms during the 10-year study period. And what about medication usage? Use of NSAIDs or acetaminophen actually decreased from 36.9% to 24.5% in the 10-year period, while the use of narcotics increased from 19.3% to 29.1% during that same period. Use of muscle relaxants and benzodiazepines increased from 19.6% to 23.7%, and use of neuropathic agents more than doubled from 3.4% to 7.9% during that same period. Remember that referrals to DCs were not measured, but referrals to physical therapy remained unchanged at approximately 20%, but referrals to other physicians increased from 6.8% to 14%. There was no observed change in the use of plain radiographs, but use of MRI or CT increased from 7.2% to 11.3%. The researchers looked at different patient populations and their access and utilization. Females, blacks, Hispanics, and other race ethnicity patients had lower odds ratios for receiving narcotic medications. Uninsured patients had lower odds ratios for being referred to other physicians. So why are we always so surprised when we are invisible to much of the healthcare system, patients, and policymakers? What might be wrong here? We have a system that doesn't capture data on chiropractors, a medical world that is largely unaware of guideline recommendations for manipulation, concerns from the medical world about safety regarding stroke with cervical manipulation and risk of disc injury with cervical and lumbar manipulation, both unfounded. We have a profession that is so inconsistent in their own management approaches that an MD cannot be sure that the treatment approaches of one chiropractor are similar to another's. We have a small but vocal proportion of our profession that doesn't want to be part of the system, which ultimately sabotages our efforts. And most importantly, we have an identity crisis in that MDs, patients, and policymakers don't view us as a serious option. Part of it may be due to the problem of big medicine and pharmaceutical companies, but part of it may be our own lack of communication through the appropriate avenues to get our message across. We are certainly a well-kept secret. Consider that a measure of the use of special imaging and surgery in a country like Canada or other social systems would reveal comparatively lower utilization. We may cry foul regarding our freedom of choice, but the reality is that when fewer imaging facilities are available and there is a longer list to have surgery, the rates in fact do go down. If you build it, they will come. If this were true in the U.S., this would at least leave a bigger time window of opportunity for conservative options that should include chiropractic. Complex problems with no easy answers, but we should take this new report as a call to action on making chiropractic visible. What if the newscaster reporting on this JAMA report conveyed a different message? A recent study in the journal JAMA Internal Medicine failed to recognize the evidence regarding the effectiveness of chiropractic care in the management of back pain. Let's investigate as to why.